All right, hello and welcome to all my coronavirus quarantinees. You've all been kicked out of school, but I say the hits must continue. So we're going to continue on. We're going to do our review. It's not in person, but I figure you can play along at home if you like and kind of see what your score would be. By nature, this is not being interactive. If you would like, we can always go back and do a. Or you can always email me. You can ask questions, whatever. No problem with that. Anyway, so let's go ahead and get started. I'm here in the building by myself, essentially. I was able to break in and weasel my way into my office, so that's where I'm at now. And, I said, as part of this quarantine, what could be sadder than a grown man playing Kahoot by himself? So let's get started. All right. So the first question is, a patient receives an inactivated vaccine today. Which of the following are true? He needs to wait at least 6 weeks before the next dose. If he misses his next appointment, he must restart the series. He can only receive other inactivated vaccines today, or he can receive a live vaccine next week. What do we think here? Well, let's see which one of these is going to be true. Basically, he can receive a live vaccine next week. If you recall that basically lives and inactivated vaccines, there's no real time frame between those. They can get them all at the same time, or there's no minimum time interval between those. The main caveat there is that it's going to be a minimum of 4 weeks between two live vaccines if they're not given at the same time. So here he has to wait at least 6 weeks. That would not be the case. It's at least 4 weeks between two live vaccines. If he misses the next appointment, certainly don't have to restart the series unless it was like, he was out of commission for, say, 5 years or something, a year. And then he can only receive other inactivated vaccines today. That is not true. He can get live inactivated. Doesn't really matter at that point. Okay. All right. I'm doing terribly so far. Let's see. Next up, acute kidney injury caused by lisinopril would be categorized as intrinsic, pre-renal, or post-renal. I'm kind of considering where at in the kidney this is going to be affecting it. If you had to imagine sort of is it happening sort of past the renal tubules, within the renal tubules, or say beforehand. And I would probably want to say that this is going to be more of a pre-renal sort of issue here. So let's see what happens. That is true. It is a pre-renal issue. It's almost like I wrote the question myself. So keep in mind with the lisinopril, if you had to imagine looking at the glomerulus with the afferent and the efferent arterioles, recall that ACE2 or angiotensin 2 is going to clamp down on that efferent arteriole, causing that back pressure to increase filtration at the glomerulus. And so if I were to say give lisinopril that inhibits the production of angiotensin 2, that's going to cause that efferent arteriole to dilate. It's going to decrease that pressure, and thus I can have an acute decrease in GFR. Again, not for most healthy patients, but if you have someone who is really reliant on that RAS system to keep them keep that GFR maintained, that can cause an acute kidney injury. But because it's happening, say, before you even really hit the glomerulus, so to speak, and the vessels beforehand or directly after, we consider that to be a pre-renal type of kidney injury. All right. Next up, which agent is the best treatment option for pregnancy-related hypertension? What do we think would be best? Would we want to give ramipril, furosemide, candesartan, or methyl-dopa? This would be a reasonable option here. Well, I'm going to say that we probably wouldn't use a lot of Lasix for hypertension in general. And so we got three other options here. What are we going to generally use? I'm going to go with methyl-dopa here. And again, that is the correct answer, because if you recall that in general, furosemide probably wouldn't be sufficient in and of itself to deal with the hypertension. We don't really use that for first-line hypertension regardless. On the other hand, though, we have an ACE inhibitor in ramipril, and then we have candesartan, which is an ARB, both of which we know to be pretty teratogenic. We need the activity of angiotensin to occur, especially in developing fetuses, depending on the receptor types you're looking at. And so this is why it's really important that we do not give these to pregnant patients. And if they do become pregnant or want to become pregnant, consider switching them to something else. Now, methyl-dopa is a bit of an older agent, kind of works by depleting some of those catecholamines such that it helps to reduce blood pressure. It's an older agent and was a drug of choice for a really long time. Nowadays, you may see other agents, things like calcium channel blockers like nifedipine being used, but this is an alternative agent you could use additionally. what or how would you adjust the dose of rosuvastatin for a patient taking ritonavir? Okay, would I use the same dose? Would I decrease the dose, increase the dose, or stop the drug altogether? So you got to think about rosuvastatin. Okay, it's a statin medication. What happens with that in terms of any interactions with ritonavir? Well, what's ritonavir going to do? Well, we know that's going to be a booster for a lot of our HIV medications. So we know that's going to be what? Say a strong 3A4 inhibitor. Okay, so what is that going to do to rosuvastatin? Well, it turns out you actually don't need to do anything for that particular one. With other statin drugs like, say, atorvastatin or simvastatin, you would have to worry about that because there is some 3A4 metabolism of those drugs that ritonavir would inhibit and thus increase the levels of. If you recall, the rosuvastatin or Crestor bypasses that by not even utilizing CYP3A4. So in this one, I wouldn't have to adjust the dose at all. So that could be a really good agent for those type of patients who are taking ritonavir, which is important because we know a lot of our protease inhibitors can cause dyslipidemia or can worsen it in those patients. All right, next up, neurosyphilis would be most appropriately treated with which medication? We want to use azithromycin, ceftriaxone, aqueous penicillin G, or benzathine penicillin G. All right, so which ones do we think is going to be most appropriate for neurosyphilis? So it sounds like a much more involved sort of case of syphilis. How do we want to manage that? Well, typically you want to stick with your penicillins. Even though we've been using penicillin for syphilis for many, many years, still tend to find that it's quite effective, does not really develop any resistance there, so that's reasonable. If it was a pretty simple case of syphilis that was not invasive, you could get away with benzathine penicillin G because it's a nice long-acting drug, just a one-time dose and they're good to go. With more involved cases like this, with like neurosyphilis, this is where you require things like continuous fusions of IV penicillin G, and so we'd want to go with this in this case here. Certainly we know things like azithromycin, ceftriaxone are going to be used for other STIs, which we may come up in other questions. We shall see. Let's see, which of the following only work when the HIV virus expresses the CCR5 receptors? Which one of these drugs is going to be looking for that? We have maraviroc, atazanavir, nelfinavir, or elvitegravir. Which ones do we think? Well, looking at it, maraviroc is actually going to be the correct one here. This is basically, again, helping with the entry of the virus into the cell, which makes sense if you look at the brand name Zell's entry. I think entry. Again, normally you're looking for that CD4 receptor to target that cell with the virus, but if it's expressing that CCR5 receptor as well, if it's looking for that protein, then yeah, it can certainly get in even easier in those cases there. The virus may mutate at some point to where this is not going to be effective because it'll basically drop the protein where it's looking for that CCR5 receptor. So because of that, this may not be sort of a good long-term drug if it develops resistance. Anyway, so again, it's important to know when looking at some of these drugs which classification they fall into, whether it's an NRTI, NNRTI, protease inhibitor, etc. Right? So you want to be able to identify those, and especially when you're looking at like different regimens that are appropriate for those patients. All right. Up next, we have controlled studies in women fail to demonstrate risk to the fetus during pregnancy. Which pregnancy category would this represent? Controlled studies in women fail to demonstrate risk to the fetus during pregnancy. You consider A, B, C, or D. Well, I would like to think that it would be considered A. If you have really good evidence in actual humans to show that it does not cause any damage to the fetus, then yeah, that would be considered a category A drug. B is going to be more for either we don't have good evidence, the good controlled studies in human patients, but you don't really see any animal data that shows that it causes harm, and we have a lot of track record of using the drug, then it gets categorized as a B in a lot of cases. Not many things fall into the A category. It's going to be things like vitamins most frequently. Remember, D is going to be used for when drugs have a known harm to the fetus, but there may be occasions where the risk to the fetus is outweighed by the benefits to the mom. So for instance, back in the day, we would use warfarin, which is a category D drug for patients with mechanical heart valves, for instance. The risk for clotting was so high that the mom, if she died of that, the fetus is certainly going to die as well. C, as I mentioned, is that drunk drawer. That's where everything falls into it if we don't have good evidence to show one way or the other. So again, not the most useful category out there. Up next, a patient misses 3 doses of her oral contraceptive product. How should she get back on schedule, or schedule, if you will? She should take 1 extra pill for 3 days and continue as normal. She should discontinue the rest of the pack and start a new one on Sunday. take the whole pack at once and restart it next Sunday, or take 3 pills today and continue as normal? Which is the correct option? Well, she should probably discontinue the rest of that pack and then start a new one on Sunday. If you recall, if it's just 1 dose, say it's on a Monday and she forgets that dose, she can take it the same day if she needs to, right? Or maybe double up the next day. If she forgets 2 doses, you can double up on 2 doses. The level should still be sufficient to where ovulation is being inhibited. If it's 3 doses or more, then yeah, you probably want to go ahead and restart on a Sunday. If Sunday is the right day they want to start, right? Depends on their schedule. Probably don't want to take the whole pack at once. Again, you may see some regimens, for instance, if you were looking at post-coital contraception. So if you didn't have access to Plan B, there are some methods of dosing birth control packs where they could take a certain number of pills in order to get sort of the similar effect there. But I would not recommend for this particular patient here. And then certainly by taking 3 pills, even though it's been long enough that where the risk for ovulation is high enough to say, hey, just use backup protection for the rest of the week when start a new pack on Sunday. Up next, what is the strategy to prevent acute kidney injury for a patient on amikacin for pneumonia? Should we ensure that the trough is above 2 micrograms per ml? Should we use Q6-hour dosing, add Lasix to their medication regimen, or place the patient on maintenance fluids? Which one of these do we think would help in order to prevent acute kidney injury if they're taking amikacin, which of course you remember is an aminoglycoside antibiotic? Well, place the patient on maintenance fluids. This is the big thing here. Just make sure the patient stays hydrated, because if they develop a pre-renal kidney injury because they're fluid depleted, then that could cause issues in terms of the amikacin being concentrated in the renal tubules and can cause that direct interstitial damage there, right? So you can see how a pre-renal can sort of precipitate or exacerbate an intrinsic sort of kidney injury in those cases there, right? Now, ensuring the trough is above 2 mics per ml, this is not right, because as you start to accumulate more drug and those troughs are higher, that actually increases your likelihood of developing acute kidney injury. We'd like these troughs to be generally undetectable if at all possible. Use Q6-hour dosing. This is also going to lead to higher troughs overall, because you're going to be dosing the drug more frequently, such that, or if you were dosing it to where the troughs were negligible, then you'd have to get such small doses that you really wouldn't get concentrations high enough to really get the sort of antibiotic kill you're looking for. So normally we would dose amikacin and other aminoglycosides, say every 8 hours. Nowadays we have switched it up and we use every 24-hour dosing to make sure we get really high peaks, but then the troughs are going to be undetectable there. And then while you can add Lasix onto a regimen, it'll make them pee, but it's not necessarily going to make sure that they're functioning, the kidneys are working any better than that. So generally this is only going to be used if the patients were maybe holding on to too much fluids. You want to get some of that extra fluid off. Up next, inactivated vaccines cause which type of immunity? Would it be booster immunity, passive, active, or innate? And of course, you would know this immediately, because you know the inactivated vaccines do cause active immunity to occur. Even though it's not a live attenuated virus or a bacteria, you're going to see that the inactivated vaccine still causes us to host an immune response against it, such that we have a memory for that, and then that's considered active immunity. Innate immunity is going to be things like the stomach being acidic or the skin being too thick for stuff to pass through. Those are innate things that we're just kind of born with that do provide some protection. Whereas passive immunity, that's going to be thinking about moms transmitting antibodies to an infant, or someone receives immune globulin, or rabies immune globulin, for instance. That's passive immunity against that particular disease state, right? Up next, which of the following could worsen hyperphosphatemia in a patient with renal osteodystrophy? It's an interesting one. Would we see that with calcium acetate, cinacalcet, calcitriol, or aluminum hydroxide? Which one of these could increase phosphate levels in someone who already had elevated phosphate levels due to renal osteodystrophy? Well, it's actually going to be calcitriol. And let's talk through about why that is. So if you recall, calcitriol is the activated form of vitamin D, right? Because we know that patients with chronic kidney disease typically have a harder time activating, if they can even activate it at all. And so what you're going to find is that will then cause basically the patient to absorb more calcium and phosphate from the GI tract. That's one of the natural actions of activated vitamin D. It'll also stimulate the kidneys to try to hold on to more calcium and phosphate. So if the patient's already having hyperphosphatemia, this can actually make it worse. Even though the overall may be vitamin D deficient, that's where something like cinacalcet can come into play, where it'll stimulate those parathyroid receptors to think, hey, we have enough vitamin D around here, without actually getting the same actions as vitamin D, and thus it'll help to block that bone resorption there, that actual osteoclast activity that's leaching all that calcium from the bone. Now, these other two agents here, calcium acetate, just by looking at the brand name, you should know that, yeah, that should get phosphate levels lower. This is going to be a phosphate binder that works in the GI tract. So phos low, because it helps to bind phosphate, and you can just eliminate it through the feces. And similarly, aluminum hydroxide could also be used for that same purpose. It'll bind phosphate, and then you just eliminate it through the feces, no problem. Up next, which of the following products would be contraindicated in a 16-year-old female with no past medical history? Be spironolactone, raloxifene, medroxyprogesterone, or ethinyl estradiol. Which one of these products would be inadvisable or contraindicated for a 16-year-old female with no past medical history? Well, that would be ethinyl estradiol. The reason why that is because we are worried about causing estrogen-dependent tumors, so especially things like endometrial cancer is a risk there, right? Because it doesn't contain any progesterones to prevent that. So if I had a young female like that, I would not want to use this for birth control, mainly because I'd worry about stimulating that tissue without having sort of the counteracting agent of progesterone. Now, you could use medroxyprogesterone by itself. That's totally reasonable. It's a depot shot, essentially, and that's fine. And then other than that, no specific issues with spironolactone. Raloxifene, if you recall, that's going to be one of our SERMs, which is a selective estrogen receptor modulator. Still has antagonistic effects in both, say, the uterine tissue and the breast, but has positive effects on the bone. I can't imagine too many cases of this being given to a 16-year-old, but again, I'm sure stranger things have happened. But this would not necessarily be contraindicated, just not very likely to be used. Up next, which drug would finish this HIV regimen? We have Zidovudine, emtricitabine, and what could I give next? Would I want to give etravirine, abacavir, lopinavir, ritonavir, or raltegravir? Which of these would be a decent option as a third medication in this particular regimen? Third or fourth, as the case may be. Well, think about this. What kind of drugs are Zidovudine and emtricitabine? Are they in the same class? Are they in different classes? This is part of that recognition of HIV meds and where they fall into the grand scheme of things. And so basically, we're going to find a couple of different right answers here. So Zidovudine and emtricitabine are both NRTIs, the nucleoside reverse transcriptase inhibitors. I would not want to use abacavir because this is also an NRTI. So I don't want to use 3 of those because I don't really get any additional benefit from that. However, what are some things I can add on to be the complete part of this regimen? Well, I can use something like an NRTI like etravirine. That's reasonable. May not be the first line regimen people recommend anymore, but it's reasonable. I could use a protease inhibitor like a boosted lopinavir. Boosting with ritonavir is perfectly reasonable. Or I could use an integrase inhibitor like raltegravir. Nowadays, these are going to be the more recommended regimens for first line for most patients who have a new diagnosis of HIV. Up next, a patient with a sodium of 110 milliequivalents per liter is seizing. Which of the following fluids would be most appropriate for them? Would I give them 0.9% sodium chloride, 0.45% sodium chloride, D5W, or 3% sodium chloride? What would be most reasonable? Well, this patient should probably get 3% sodium chloride. The reason being is this is the key word here. They're seizing, they're acutely symptomatic. You need to do something about that right away. Now, if you recall, what's the max amount that you'd want to increase that by, say in a 24-hour period? Well, by about 12 milliequivalents per liter. So I'd probably only want to get him up to about 122 in the first 24 hours. Now, is that within the normal range of 135 to 145? No, but he'll probably stop seizing by that point there. And so again, this is a very careful thing you have to do, because if you over-adjust it too quickly, certainly you would end up developing risk for essential pontimyelinolysis, right? So let's look at the other options here. So certainly D5W, that would not help. If anything, that would just dilute out that sodium even further. That's not good. The half normal saline here is only 77 milliequivalents per liter of sodium, and so again, that would also worsen our case here. Now, normal saline, being 154 milliequivalents per liter, could be used in conjunction with the 3% sodium chloride once the seizing is discontinued. Once it's been resolved, then you could consider using something like normal saline. So basically, you just maybe start off with a bolus here of the 3% saline to get the patient seizing under control once they have sort of stabilized. Then you can look at see what their new sodium level is, and then adjust the rest of it based off of this using normal saline. That'd be pretty reasonable, assuming the patient's not fluid overloaded for any reason. All right. Up next, acute kidney injury from cisplatin would be categorized as post-renal, pre-renal, or intrinsic. So last time we saw with the lisinopril, that was a pre-renal issue. What is cisplatin doing? If you recall, it's an alkylating agent, it's a chemotherapeutic drug. This one's going to cause intrinsic damage, right? It's going to alkylate DNA in those cells in the renal tubules and cause direct injury. So it's an intrinsic injury you're going to be seeing there, as opposed to working sort of either pre or post the kidney itself. So again, keep in mind the mechanism of the drug, and it makes sense in terms of what kind of injury it's going to cause based on that mechanism. Up next, the first line treatment for gestational diabetes would be glyburide, metformin, regular insulin, or dietary modification. What do we think with this one? No, I'm just kidding. You guys don't know this one's pretty easy one. Yeah, dietary modification. That's always going to be ideal, because the right kind of drug for a pregnant patient is no drug if you can make it happen, right? There have been cases where, I mean, obviously the first line thing you'd want to go with would be regular insulin if you had to do it. This is something where, again, it's not great from a compliance standpoint, because no one wants to start giving themselves injections just because they're pregnant, but that would be the safest thing to give, because regular insulin looks just like our insulin from an amino acid standpoint. Very low risk to the fetus, low to none. Metformin has been used occasionally to help out with patients with insulin sensitivity issues, but again, probably not going to be recommended as first line. And then glyburide can even cause like depletion of insulin from the fetal pancreas, so not typically recommended in a lot of cases there. But if you can fix it with dietary modification, that's generally going to be the most beneficial for those patients, which makes pretty good sense. Sulfamethoxazole and trimethoprim is used to treat which opportunistic infection in patients with HIV, or maybe they're immunocompromised due to cancer treatment or something like that? Would it be cytomegalovirus, PJP pneumonia, Mycobacterium avium complex, or oropharyngeal candidiasis? And you all should know this. It's going to be PJP pneumonia, right? Obviously, cytomegalovirus is a viral thing, so it's not going to be treated by an antibiotic. Similarly, oropharyngeal candidiasis is a fungal thing, so that would be either nystatin or fluconazole you want to use for that. And then Mycobacterium avium complex is a more atypical kind of pathogen. Typically, you see a lot of things like macrolides being used potentially, but certainly for PJP pneumonia, both for prophylaxis, once patients get down below, say, 200 CD4 cell count, or for actual treatment in and of itself, then Bactrim is the way to go for this. And again, this is a pretty devastating type of infection if these patients get it, so you want to be really on your game about making sure that patients are prophylaxed when they need it, and then making sure to recognize it early to treat it before patients kind of go down the drain from that particular disease state. Up next, we have which of the following should prompt immediate discontinuation of oral contraceptives? Be acute chest pain, intermittent headaches, breakthrough bleeding, or skin hyperpigmentation. Well, which one of these sounds like an emergent sort of condition? Most of you should know this. Yes, that would be acute chest pain. Why are we concerned about acute chest pain in someone taking oral contraceptives? Well, you would, I'm sure you're right now correctly saying that oral contraceptives, in particular estrogen, is going to increase clotting factor production and put the patient in a hypercoagulable state, right? So maybe this started off as a DVT that dislodged, is now causing an acute PE. At least you need to rule it out, right? Breakthrough bleeding is a known side effect. It's not something that I would be overly concerned about unless it was quite heavy for those patients there, but abnormal breakthrough bleeding, especially during the first 3 months, it's pretty typical. Skin hyperpigmentation may be a reason the patient wants to discontinue it, but it doesn't prompt immediate discontinuation, but again, another known side effect. And then intermittent headaches. Now, obviously, if it was like a very severe headache or they had any stroke-like symptoms, then yeah, they should stop taking it. But keep in mind, especially patients with the history of migraines, some estrogen or some oral contraceptives help their migraines. Sometimes it makes it worse depending on the situation. So intermittent headaches, I don't know that I necessarily would immediately discontinue it unless I heard some kind of warning signs like it's the worst headache of their life, or that any sort of stroke-like symptoms go along with that. All right, which patient would produce the best response to an inactivated vaccine? A 6-year-old male under active treatment for leukemia, a 14-day-old infant with no medical problems, a 26-year-old male with HIV/AIDS, or a 16-year-old female? Who would have the best response to an inactivated vaccine? This question probably does not seem too difficult, but again, I'll use these to make a point. It would obviously be the 16-year-old female with no issues here. So let's look at the other options, though, to see why they are incorrect. So the 6-year-old who's under active treatment for leukemia, obviously they're in an immunocompromised state. Their white count should be relatively low to where they cannot mount a very good response to an inactivated vaccine. Does that mean they can't receive it? No, it just means they're not going to have a very good response. But again, the benefits of having some response is better than the downside of nothing happening, right? So in this case here, it would not be contraindication, just a precaution, right? 26-year-old male with HIV/AIDS. Now this is going to be dependent on what their CD4 count is. If it's particularly low, say less than 200, yeah, they're going to have a harder time mounting a response. But if they're under pretty good treatment and they are well controlled, the CD4 count's over 200, they're more likely to have a good response to that. So again, a precaution. A 14-year-old infant, again, they are going to have probably the least ability to mount that response, just sort of at a baseline, depending on kind of what the situation is, mainly because, again, they have a lot of host immunity from mom helping out with that, passing on antibodies, and then, again, they just don't have a really good, competent immune system. That doesn't mean we don't give them any vaccines, but, again, they're maybe more likely to have a diminished response as compared to someone with a fully constituted immune system. And our last question here is, which of the following is an abortifacient, but is also used to induce labor? We use misoprostol, oxytocin, nifedipine, or terbutaline. Which one of these could be used to help cause an abortion to occur, or can actually be used to induce labor, which I'll tell you is actually the same exact mechanism. Well, it's going to be misoprostol here, right? This is a synthetic prostaglandin, and we know this causes uterine contractions to occur, and so we can use this for that particular purpose. We probably know this one to be used more frequently for prevention of NSAID-related ulcers, or to help out with healing for NSAID-related ulcers. How about these other agents, though? So, for instance, oxytocin itself is not used as an abortifacient, but is also helpful for helping to induce labor. So we'll typically give that as an IV infusion, and that helps to increase contraction of the uterus. The reason why this is not really a good abortifacient is mainly because when patients are closer to going into labor, they actually have an upregulation of oxytocin receptors. Earlier on, they don't really see that, so it really wouldn't be used for that particular purpose. Nifedipine and terbutaline are both agents that help to prevent premature contractions. Nifedipine blocking calcium channels to help prevent that smooth muscle from contracting. Similarly, terbutaline, by activating beta-2 receptors, also causes a smooth muscle relaxing sort of effect. So again, kind of doing the same thing, but via different mechanisms. So, boy, I did pretty bad here. I'm not gonna lie, guys. I got 0 points overall, so I don't get a free answer, but I'll tell you, you're all winners in my hearts. And stay safe out there. Wash your hands, and your free answer is B. Thanks a lot. If you have any questions, please feel free to let me know. Again, we'll play it by ear. We'll see when the test happens. If there's any changes, you'll certainly be the first ones to know. Otherwise, I will see you when I see you. Thanks a lot. Bye.